Let's take a moment to start the webinar with a welcome video. Thank you so much everyone for watching. So now let's get started with our today's session. So very good evening and warm welcome to all the dignitaries present here. I am Momita from ClearNet, serving as the allocated session assistant to ensure a seamless experience. ClearNet stands as India's most relied upon digital platform, offering a multitude of enriching services exclusively for doctors. It is with great pride that Planet serves as the digital partner for this event hosted by Indian College of Anesthesiologists, and the focus of today's session is advanced hemodynamic monitoring. So now, without any much delay, I would like to hand over the session to Dr. Muralidhar Kanchi, sir. Sir, please take over. Thank you so much. Over to you, sir.
Thank you. Thank you so much. And it's a great pleasure and honor for me to invite you for this Wednesday webinar of the ICA. Wednesday webinar of the ICA has become a hallmark of Indian College of Anesthesiologists. And we all look forward to it because there is a quality material being presented by experts, and there is a useful interaction, a lot of things to learn and update ourselves. So with that, I would like to, with that small bit of introduction, I would like to invite Dr. Ratan Gupta, who is the intensive care um physician. He's a cardiac intensivist working Narayana Hrudayalaya for a long time. extremely experienced, and Dr. Poonam Malhotra is yet to join. Dr. Jigisha is from UN Mehta Hospitals in Ahmedabad. Thank you so much, Dr. Jigisha, for joining us. And I'll be with you all through. And with this, I would like to hand over to Dr. Ratan Gupta to start the session.
Good evening. Thank you, Dr. Murali, for allowing me to participate in this advanced hemodynamic monitoring session. I invite Dr. Satyajit Mishra from Bhubaneswar to go ahead with this presentation. Dr. Satyajit Mishra is Professor of Anesthesiology and Critical Care at AIMS Bhubaneswar. And I invite him to talk on arterial pressure monitoring and hypotension. Over to you, Dr. Satyajit Mishra.
Yeah, thank you so much, sir, and good evening to everyone. At the outset, I'd like to thank Murli sir for giving me the privilege and honor to be a part of today's webinar for the ICA. And good evening to my fellow panelists and moderators and all other esteemed audience that have assembled for today's webinar. I'll be speaking to you over the next few minutes about arterial pressure and the hypertension prediction index. And I do not have any conflicts of interests or any disclosures to make. And through the course of this talk, I'll be using the example of the Edwards Acumen monitor, which is the one that comes in with the HPI algorithms. But that's not a brand promotion. It's a necessity because there is no other company that does this. So I'll be using the example of this monitor for illustrating my points. How we're going to go through this talk in the next 14 odd minutes is first I'll describe why hypertension is a problem for all of us, and where the use of artificial intelligence comes in arterial waveform analysis, which is integrated to generate this hypertension prediction index, and how in turn this hypertension prediction index is integrated in the comprehensive hemodynamic management of patients. I'll end with a few proof of concept papers, and finally, I'll round off the pitfalls of hypertension prediction index monitoring. Now, all of us monitor the arterial pressures every single day, whether we are working in the operating rooms or whether we are in the ICUs or elsewhere. And the reason we do that is because of this gentleman who was a German physicist and told us about the Ohm's law, which basically tells you how the current across a resistance is a function of the voltage and the resistance across the circuit. And if we apply the same principle to the flow dynamics, the flow times resistance is proportional to the pressure. And if we just substitute the flow for cardiac output and the resistance for systemic vascular resistance and the pressure for the mean arterial pressure, then the cardiac output into the systemic vascular resistance is proportional to the mean arterial pressure. And if we assume the resistance is constant, then the cardiac output varies directly as the mean arterial pressure. So we assume that if the mean arterial pressure is coming down, the cardiac output is coming down, and the perfusion to the organs may be compromised, which is why arterial pressure monitoring is sine qua non in any patient who is undergoing anesthesia and surgery. But when you look at the problems with the routine blood pressure monitoring as we have it currently, it tells you the event when it happens. So it obviously cannot predict the event before it occurs. And it doesn't also allow us to differentiate the various causes of hypertension. For example, a mean arterial pressure of less than 65 may be due to hypovolemia, may be due to impaired contractility, may be due to vasoplegia, and so on and so forth. So obviously the treatment for each type is going to be different. And therefore, we would not know just by looking at the numbers what is the cause of this hypertension. And therefore, we cannot institute any preventive measures because we don't have any predictive value of this monitoring. Now, we know that a lot of money is put in predicting adverse events, cyclones or tornadoes or typhoons. And the reason it's done is because lives can be saved. Now, it's surprising that until recently, we didn't have this kind of predictive abilities for intraoperative hypertension. And it is surprising when you look at how common it is. It's quite common. If you look at patients who underwent non-cardiac surgery, around 88% of these patients experience a hypertensive event, which is a mean arterial pressure of less than 65 millimeters of mercury for 1 minute. And it's common across all age groups and across all types of non-cardiac surgery. And it's even the risk is even there in younger patients. So what happens when there is hypotension? This good paper in anesthesiology in 2017 showed us that when you have a mean arterial pressure of less than 65 millimeters of mercury, it is directly associated with end organ injury. Look at the left panel, which is the probability of myocardial injury. And this curve, these dotted lines and the bold line shows the temporal duration of hypotension. For example, if you look at the lowest part of the curve, that's hypotension for cumulative duration of 1 minute. The probability of myocardial injury is roughly around 1.5%. But when that duration increases to 10 minutes, the probability of myocardial injury becomes more than 3%. So the risk almost doubles. The same thing happens for acute kidney injuries. The more the time duration of hypotension below 65 millimeters of mercury, more is the chance of acute kidney injury in these patients. Let me put to you a very interesting model that was performed. An experiment was performed to show what are the effects of the hypotensive event on the organs. So this was a controlled model of hemorrhage in pigs. And the left panel shows basically normal gut mucosa with normal perfusion. Now, after 5 minutes of after 5 minutes of hemorrhage, after 5 minutes of hypotension, you can now see clearly that the gut mucosa is now edematous, and the blood vessels are all the perfusion is also decreased. And when the temporal duration of hypotension increases to around 10 minutes, the gut mucosa has become totally blanched and pearly white, and there's no perfusion. So this is exactly what happens when the hypertension is there for a long period of time. And the same changes are pretty much there in our body also. Now, when we look at the gadgets or the apps that govern us in our daily life, the common link is artificial intelligence. And therefore, it's not very surprising that the same artificial intelligence is now being used to, to benefit the patients who are undergoing surgery. And it has been the hypertension prediction index, or the HPI, has been generated using machine learning algorithms. And the current technology that's there in the market is from the Edwards Hemosphere monitor using the Acumen IQ technology. Earlier, it was not available for the non-invasive blood pressure cuff, but now they have come in with the hypertension prediction index for even the non-invasive blood pressure monitoring. So what it does, the HPI, it basically predicts the probability of hypertension, and the algorithm defined is a mean arterial pressure of less than 65 millimeters of mercury for 1 minute. And it gives us values from 0 to 100. So these values are unitless. So they go from 0 to 100. And higher the value, there's a higher probability of the patient developing a hypertensive event in the next few minutes. So if the number reads 85, that means there's an 85% probability that there'll be a chance of a hypertension in the next 5 odd minutes. Now, if you have two very high readings, and the cutoff is around 85, so if you have two very high readings of 85% or more within 20 seconds, then there is a very high probability of the hypotensive event occurring even less than 5 minutes. The first proof of concept was reported in 2018 in anesthesiology by Hatib et al. And basically, they used the machine learning models. They analyzed the waveform of individuals who underwent various types of surgeries and and had hypertension. So they had approximately 3,000 individual arterial features per cardiac cycle, which were analyzed, and over 2.6 million features were analyzed overall. And they found that it gives a very good specificity and sensitivity for predicting hypertension before the event actually happens. And closer the event is going to occur, the sensitivity and specificity increases for the predictive values. So these were the various arterial waveform features that were extracted. So you can look at the part depicting compliance, the area under the curve depicting the stroke volume, the vascular tone or the afterload, the full cardiac cycle, the initial upstroke, which tells the contracted degree. So all these features were extracted to use a predictive algorithm which tells us whether the hypertension is going to happen before it has actually happened. And what they found is that there are subtle changes in the waveform long before the hypotensive event actually happens. So there would be changes in either the aortic compliance or in the contractility and so on and so forth. And these changes sort of gives the predictive capability of the system to tell you the event before the index event actually happens. So how it helps us? It helps us from being it helps us in being proactive rather than being reactive. For example, if we usually are at a phase where we start the treatment after the hypotension happens, and by that time some duration of hypotension has already happened. And if you remember that initial slide that I showed to you, where there was the blanching of the gut mucosa, so you can well understand that by the time we institute most of our treatment measures, some amount of end organ damage has already occurred. Whether the patient bears the consequence of it would depend on a whole lot of other factors. But the HPI helps us in being proactive. That means that it tells us the probability of the event happening before it has actually happened. And so it allows us to institute measures which sort of prevents this index episode from happening. So let us come to how the screen looks like. So the screen is the standard, this is the Hemosphere screen. So you have on the top panel, you have the arterial waveform tracing. And you can see that the numbers are looking pretty much normal. But if you look at the second panel, that is the HPI, and the HPI shows a value of 83 by 100. And like I said, if the numbers are high, that means there's a high probability of a hypotensive event happening in the next few minutes. So if it's 83, that means in the next 5 to 7 minutes, there's an 83% chance of a hypotensive event happening. And this is at a time when all these numbers are looking just perfectly fine. So if you look at this chart on the right panel, you look at the bottom numbers. So anytime it starts hitting 85, the time to the index event comes down to roughly 5 minutes. So if it's 85, it's roughly 5 minutes that there'll be a hypotensive event. In the next 5 minutes, there's going to be a hypotensive event. And as the number increases, the time to the index event comes down. So when you're having a number around 94 and above, the time to the event is going to be less than 3 minutes. And when you have two such high values consecutively within 20 seconds, it is going to prompt you to review the secondary screen so as to discriminate what is the cause of hypotension. If you remember, I said, if you're just looking at the mean arterial pressure, you will not know what is the cause of the hypotension, whether it's due to a preload problem or an afterload problem or a contractility problem. But here, this screen is going to pretty much tell you where the problem lies. So once you see the number on the top right that shows 94 by 100. So that means that there's a 94% chance that this patient is going to have a hypotensive event in the next 1 to 2 minutes. And that's when the map is around 73. So there's nothing that tells you that this patient is going to is having hypotension, because this map is perfectly fine. But if you just go by this map, you would miss that fact that this patient is going to have a hypertension in the next few minutes if you don't have HPI. Now, when you look at the secondary screen, then it tells you whether the pulse rate is okay, the stroke volume is okay, and all the determinants of the stroke volume, like the stroke volume variation, the contractility, and the afterload, whether there's a problem. So if the stroke volume is high, stroke volume variation is high, it might mean that there is a need to give fluids. Contractility is low, it might mean that there's a need to start inotropes, and so on and so forth. So when you take a look at the secondary screen, all the factors that influence the stroke volume are there, like the preload, the contractility, and the afterload, and therefore your management pathway is much more accurate. So, sorry. So this is the advantage of the HPI is, apart from the numbers, it tells you if there's a contractility problem. So the DPDT is nothing but the rate of the rise of the upstroke, systolic upstroke. So it tells you if the DPDT is low, that means that there's a contractility problem. Similarly, if the EA-dyne is nothing but the arterial elastance, so dynamic elastance. So it tells you whether it's an afterload problem. In other words, if you are at a high part of the So if you give volume, then this patient is going to respond to the volume by increasing the pressure. If you're on the lower part of the compliance curve, if you give volume, this patient is unlikely to increase the pressure in response to a volume infusion, and probably you need to start thinking of giving vasopressors. But the problem is the cost. If you have the standard flow track, which gives you everything except the HPI and the DPDT and the EA-dyne, the cost is around 12,000. But if you include the HPI, then the cost doubles to around 23,000 or 24,000 per patient. So this is how the screen looks like. So let me just play this video. So you can see here that all these values are looking perfectly fine. The stroke volume is good. The cardiac index is good. The cardiac output is good. And the HPI is very low. So it's very unlikely this patient is going to have a hypotensive event. And when I touch this secondary screen, you get all the variables that can impact the patient's hemodynamic status. And therefore you can make the management. So when you look at these papers, let's round up with a few papers. So this came in JAMA, and they showed that if there is a machine learning algorithm that is used, then there is less intraoperative hypotension in patients who are undergoing surgery. Similarly, Other papers also show that when you're using the HPI algorithm with a protocolized goal-directed treatment, the incidence and the duration of hypotensive events is reduced in patients undergoing primary hip arthroplasty. Another retrospective study tells us that if you use the HPI, then there are less postoperative complications and a lower length of stay in the hospital. So is it all great? No, not necessarily. If you look at some papers which have differed, this good paper came in anesthesiology in 2020, and they looked at the hypertension prediction index to guide the intraoperative hypertension. And what they found is if the clinicians are not following the alerts, then it doesn't make a difference whether you're following a standard management pathway or whether you're using the HPI in managing your patients. So if you're not going to act upon these alarms, then probably the duration and the number of hypertensive events are going to be the same, whether you're using HPI monitoring or whether you're not using HPI monitoring. So what are the various pitfalls? Now, the first thing is if there is a time to the event, so it's not going to be able to tell you sudden drops in hypotension, blood pressure. For example, if the patient, there's a vascular clamp that is released, or if the bolus of anesthetics are given, when there is lap insufflation, sudden hemorrhage, and so on and so forth, it will not be able to tell you, it will not be able to give you that predictive value because the time to the event is sudden. It's still not validated in children less than 12 years, so it can't be used in children less than 12 years. Not validated in the ICU population because the initial validation model that was tested by Hatib et al. Was actually tested in patients who were undergoing non-cardiac surgery, and they didn't test the validation model in the ICU population. And when you look at hypertensive individuals, the threshold of 65 millimeters of mercury that the company uses may be actually quite low because the autoregulation is shifted to the right in such individuals. But what I was told by the company people is they are working on individualized hypotensive thresholds. So in the future, you can set your own lower limit of the mean arterial pressure, which will sort of be used by the monitor to sort of give you the alarms if the event is going to happen in a few minutes. And obviously in open chest models, because the preload and the stroke volume variation and all those things are not valid. So when you look at the causes of hypertension and whether preload is a problem, we can't say for sure because the heart-lung interaction is lost in open chest models. So these are the various issues with the hypertension prediction index as it currently stands. But definitely it's a thing in the future, and probably if the costs can be taken care of, it would be more commonly seen in the intraoperative environment. With that, I would like to thank my presentations, and once again thanks to the ICA for giving me this opportunity to have this presentation. Thank you.
Thank you, Dr. Satyajit Mishra. That was a wonderful presentation. It was very lucid, and the question and answers will be taken at the end of the presentation. So be there, and I invite Dr. Poonam Malhotra to introduce the next speaker.
I'm not sure if Poonam has joined.
Okay.
So I take pleasure to invite Dr.
Sure,
Vinod.
sir.
Vinod. Dr. Vinod, can you please share your screen? Dr. Vinod is a senior consultant in Shankara Cancer Institute in Bangalore. He is very well known in this field of onco-anesthesia, and he's also expert in pain management. And I request Vinod to share his slide and go ahead with his presentation. He will be talking to us about totally non-invasive cardiac output measurement. I think he has extensive experience in the use of bioreflectance technique of cardiac output measurements. And we would like to listen to him, what he has to say.
Good evening, sir. Thank you very much for the kind introduction. My topic is role of bioreactants in the measurement of cardiac output. I have no disclosures to make except that I'll be using the example of Starling monitor, which is the only monitor which works on the principle of bioreactants. So we know that a lot of data suggests that early aggressive resuscitation of critically ill patients may limit or reverse the tissue hypoxia, which lead to progression of organs failure or to improve the outcome. So the first step in hemodynamic management of a critically ill patient is to determine the adequacy of tissue perfusion and organ perfusion. Although the signs of shock may be obvious, the signs of subclinical shock may be very subtle. And it is seen that only in 50% of the hemodynamically unstable patients, they respond to volume resuscitation. In such situations, it is very important for us to guide our fluid administration based on the cardiac output and the stroke volume responsiveness, lest we overload the patients. So in coming to the cardiac output monitoring, it is very important in all those patients who are undergoing any major surgery, those who are critically ill, those who are injured and unstable, because it provides us an indication of the systemic oxygen delivery and the global tissue perfusion. It also defines the overall performance and function of the heart, and it predicts the prognosis and survival in heart failure. And also it helps us in risk stratification. Usually the thermodilution method using the pulmonary arterial catheter is considered as a gold standard for monitoring of the cardiac output, but it has its own set of limitations in the form like it is invasive, it is expensive, it requires special skills to be inserted, and it is associated with some of the catheter-related complications like infection, bleeding, and arrhythmias. Over the decades, several minimally invasive and non-invasive methods of measuring cardiac output have been developed. Most of them are safe. All of them have limitations in the form of accuracy and reliability when compared to the thermodilution method. Over the century, this is the evolution of methods which have been used for measurement of cardiac output. Initially, it was only the blood pressure monitoring in the 1900s. The pulmonary artery catheter was introduced in 1970s. And in the 1980s, it was mainly the echocardiogram which was being used for measuring the cardiac output. Since the 2000, there have been dynamic assessments of cardiac output measurement in the form of invasive monitors and non-invasive monitors. The invasive monitors included the stroke volume variation, pulse pressure variation, but all of these required the insertion of an arterial catheter. And now we have the non-invasive methods of measuring cardiac output. Amongst the non-invasive measures of cardiac output monitoring, we have the bioimpedance and the bioreactance. Basically, they share some of the principles, but in some ways they are different. The thoracic electrical impedance, bioimpedance, is based on the assumption that changes in intrathoracic blood volume during the cardiac cycle induces changes in the electrical conductivity of the thorax, and that are mainly related to changes in the aortic volume. It is based more on amplitude modulation. And these monitors face certain technical and pathophysiological limitations due to extraneous electrical interference, making them less suitable. Whereas the bioreactance is based on the frequency modulation and phase shift. So this Starling monitor, which is based on the bioreactance model, works on phase shift or time delay. And unlike the bioimpedance, the bioreactance is not affected by the size of the patient, presence of thoracic fluids like pleural effusion, pulmonary edema, or position of sensors. The first version of the non-invasive cardiac output monitor, or the NICOM, was manufactured by Cheetah Medicals in the Newton Center, Massachusetts. This was used as a reference standard, which has been validated with other cardiac output monitoring systems like the pulse contour analysis and the pulmonary arterial catheter. The initial versions of this monitor provided cardiac output readings, which were averaged over 30 seconds. Hence, there were some concerns regarding its ability to track rapid changes in the stroke volume. The present Starling device has an averaging of about 8 seconds. In this machine, we have 4 non-invasive sensor pads which are applied to the thorax, which are creating a box around the heart. There's a small electrical current of 75 kilohertz alternating current, which is induced through the electrodes. Usually, it is the voltage signal is recorded between it is induced from the outer signals, and the signal is recorded between the inner pair of sensors. The flow of blood in the thorax induces a time delay or a phase shift in the signal, and this monitor uses this phase shift as the baseline for stroke volume measurements. These signal changes have been correlated to the known thermodilution cardiac output monitoring in more than 65% of patient samples in many of the clinical settings, like in the ICU, operating theater, or the cath lab. So the bioreactance assesses the pulsatile flow-induced frequency modulations and phase shifts in voltage across the thorax. And there's a 100-fold reduction in the impact of extraneous electrical fields on the on the cardiac output estimates. A non-invasive cardiac output measurement signal is determined separately from each side of the body, and the final cardiac output is obtained as an average. So this is the algorithm in which this Starling stroke volume is measured. Current is applied to the thorax by the sensors. The Starling monitor detects the time delay between the applied current and the voltage on the chest. And based on this, a flow signal is derived from the time delay. This measures the maximum dxdt, that is the maximum flow, and also the ventricular ejection time. And based on a proprietary algorithm, the stroke volume and the cardiac output is determined. So assessment of fluid responsiveness using this monitor can be done by using two methods. One is the passive leg raise test, and the second one is using the bolus. The passive leg raise test is a simple test which involves elevating the legs to about 45 degrees from an initial semi-recumbent position. It leads to an auto transfusion of about 250 to 300 ml of blood from the lower extremities to the pelvic veins. Increase in the detection of stroke volume more than 10%, that is delta stroke volume index more than 10%, indicates that the patient is likely to be fluid responsive. And if it is less than 10%, it indicates that the patient is not likely to be responsive. So this has been shown to be pretty accurate predictor of the fluid responsiveness with a sensitivity of 97% and a specificity of 94%. The other method is by administering a fluid bolus of about 250 ml in less than 5 minutes or 500 ml in less than 10 minutes and measuring the increase in stroke volume, that is the delta stroke volume index. So this is how the monitor looks like. You have the basic parameters and you also have the buttons where you can start the passive leg raise test or starting the bolus test. The other parameters which can be measured by this monitor is the cardiac output, cardiac index. You have the thoracic fluid content and the peripheral resistance. And this is when we are measuring the stroke volume variation, stroke volume index, and you have the clinical ranges also, which are displayed in the monitor. And when we are giving the bolus, this is how the monitor guides us. It tells us when to end the bolus based on the timing which we are setting here. And once the bolus or the PLR test is done, if the patient is responsive, it will give that the patient is responsive by giving the delta SVI, which is more than 10. And if the patient is not responsive, that is the delta SVI is less than 10%, then it will clearly indicate that the patient is on the flat line of the Starling's curve. And it means that the patient is not fluid responsive. So I would like to demonstrate this by a few clinical case presentations. In the first case, it's a 79-year-old male patient who was posted for a robotic radical prostatectomy. Patient is a known diabetic, hypertensive, he's also got ischemic heart disease with an ejection fraction of 51%, and there's no regional wall motion abnormality. His revised cardiac risk index is 2 points and body surface area is 1.81. Patient was operated in steep Trendelenburg position because it was a robotic radical prostatectomy. So these are his values on the Starling monitor. This was a pre-induction value. As you can see here, the stroke volume index is around 30 and the cardiac index is 2.5. And once the patient has been put in steep Trendelenburg position, the stroke volume index has gone up to 43.3 and the cardiac index has gone to 4.2. Once we had an episode of hypotension, we gave a fluid bolus, but we noticed that the increase in the stroke volume index is not significant. So the cardiac index is also not significantly increased. The stroke volume index, the delta SVI is negative. It is only about 6%. Hence, we can derive that the patient is not responsive to the fluid bolus. Another thing which we can notice from this table is the thoracic fluid content. The normal thoracic fluid content should be less than 45, whereas right at the time of pre-induction itself, we have a thoracic fluid content of about 48.4, which indicates that the patient is already slightly leaning towards volume overload. Despite that, just to check, we gave the fluid bolus. And if you see that with the induction itself, it has gone to 53. And with the fluid bolus, it has gone to 56.3, which indicates that the patient is already fluid overloaded. And in this patient, we cannot give any further fluids. We need to manage by giving vasopressors and inotropes. This is the second case presentation. This was a 74-year-old male patient who was posted for a wide local excision of carcinoma of the buccal mucosa with the neck dissection and reconstruction using a free radial artery free flap. He is also a diabetic, hypotensive. Ejection fraction is 60%, body surface area of 2.22 meters per square feet. And he is known case of obstructive sleep apnea and has also got a mild restrictive pulmonary function. He gives history of dyspnea on exertion. This patient was operated in supine position, and these are his values. So during the pre-induction phase, the stroke volume index is 27.56 and the cardiac index is 3. At induction, there's no significant change in the stroke volume index, but the cardiac index has come down slightly because of the anesthetic agents. We had 2 episodes of hypotension during the surgery. In the first episode, when we administered the fluid bolus, there was a significant improvement in the stroke volume index, which was more than 10%. And also the cardiac index also has responded well. So we could continue with fluid bolus and we managed with fluid bolus. Whereas in the second episode of hypotension, we noticed that there is no significant improvement in the stroke volume index or the cardiac index. And at the same time, we also noticed that the thoracic fluid content with the first bolus is well within normal limits, but with the second bolus, it has gone beyond the limit of 45. So this indicates that after the first fluid bolus, the patient has become volume adequate, and further fluid infusion or fluid boluses is not going to improve his cardiac index or cardiac output. So he needs the inotropes to improve his blood pressure. So this is how we can use the monitor. So there are several advantages of using this non-invasive monitor. The main thing is the ability to monitor the cardiac output of patients without having any invasive central or arterial lines. And we can use it on those patients who are either on or off the ventilator. We need not worry about the tidal volume or any problem, any arrhythmias or anything like that. We can use the monitor in the operation theater or in the ICU. It is very user-friendly and it's consistent and comparable to any other invasive device. There's one important disadvantage in this, which is quite limited. It is seen in situations where there is no association between aortic systolic deformation and the stroke volume. That is in patients with aortic dissection or those having aortic processes. And of course, in neonates, because of the size of the electrodes, which will occupy almost the entire body of the neonate, it may not be very significant. Now, the effectiveness of this Starling monitor has been validated in several clinical settings with over 100 peer-reviewed publications on the monitor itself. I'll just show a couple of them. The validity studies have been done by Paul Marek et al. And Chung also. Here they've shown that in post-cardiac surgery patients, NICOM was compared to the pulmonary arterial catheter technique with good correlation observed. And by Raval and Squara, they've shown that in a multi-center study of intensive care patients, the NICOM, pulmonary arterial catheter fixed principle, and the bioreactance technique were simultaneously compared. And in the subset analysis, NICOM had better correlation to pulmonary arterial catheter than the other techniques. Even in this study, they have seen in major abdominal surgery patients and post-cardiac surgery patients, NICOM was compared to the flow track system with good agreement between these two techniques which were seen. Square et al. Studied the performance of NICOM by using PICO device as reference. And NICOM was also showed a good agreement with the PICO system. So to summarize, bioreactance method using the Starling monitor has been shown to be a safe and reliable monitor of cardiac output. It uses frequency modulation and phase shifts to measure the variables. It provides reasonable accuracy in monitoring fluid responsiveness in major surgeries and in critically ill patients. And the accuracy is not affected by use of vasopressors or in severe shock states. It is well understood that it is not possible to have one absolutely faultless technique or monitor to measure the cardiac output and fluid guidance in all the situations. In addition to monitoring, other markers of tissue hypoxia like lactates and central venous oxygen saturation help in guiding fluids. Thank you.
Thank you, Dr. Vinod, for that brilliant presentation. And you have highlighted the use of absolutely non-invasive techniques to get useful information in patients who need them. Thank you so much. Please stay till the end of the session because there are some questions which is addressed to you. You might have to answer them. Please stay back.
Yes.
With that, I would like to request Dr. Jigisha to take over and invite the next speaker and proceed with the session. As you know, Dr. Jigisha Sachade is a um, experienced and well-known anesthesiologist, cardiac anesthesiologist from Ahmedabad. And Dr. Jigisha, it's for you now.
Our next speaker is Dr. Manoj Kamal. He will speak about the calibrated arterial pulse contour for the cardiac output monitoring. Sir is a senior professor affiliated with the Department of Anesthesiology and Critical Care, AIIMS Jodhpur. Sir is having 84 publication, and he was, as we all know, he was excellent when we had attended the conference at ICA conference, Jodhpur in 2022. He was organizing secretary. Over to Dr. Kamal, sir. Dr. Manoj Kamal, you can please start your presentation.
Am I audible?
Yes, you are, Dr. Manoj.
Yes.
Welcome. Yes, you are.
Thank you, madam. And thank you, Kanchi sir, for giving me this opportunity. And I am going to speak on pulse contour analysis methods, which are calibrated in nature. And I have nothing to disclose. As we all know, the cardiac output is important modality in especially in high risk major surgical procedure. And by using early goal directed therapy, we can titrate the fluid, vasopressor, and inotrope. And pulmonary artery catheterization is gold standard method to know the cardiac output. But nowadays, because of invasiveness, less invasive modalities are available. And among that, pulse contour analysis is one of the most frequently used technology. And as we all know, the basic concept of arterial pulse contour as pulse wave is the mathematical analysis of arterial blood pressure waveform, and it estimates cardiac output continuously in real-time method. And it is the pressure difference, which pressure gradient that impels fluid to flow in the blood vessel. And by measuring the pressure difference at the two level, and we converted this pressure difference into the volume measurement so that operator must ensure that arterial waveform is neither overdamped or not underdamped for arterial pulse contour analysis method. And pulse contour analysis method is, as we all know, that arterial pressure waveform is a complex physiological signal that interplay between stroke volume, SVR, vascular compliance, and valve wave reflectance phenomena. And by seeing the shape of the waveform, we can indicate the cardiac health. It indicates the cardiac health as well as vascular condition. When we compare the cardiac output assessment by pulse contour analysis and thermodilution in patient with cardiac surgery or any other major surgery, when we compared with intermittent femoral artery thermodilution and PAC, the pulse contour analysis enables accurate measurement of continuous cardiac output in patient undergoing mid-cap surgery. There are certain challenges for pulse contour analysis method. As we all know, the downstream waveform is not as same as upstream waveform. And the gradient of pressure determines the magnitude of acceleration and deceleration. It is the diameter of the vessel that dictates the actual volume of the blood. And it is only within the aortic root that flow equals to the cardiac output, whereas arterial waveform is usually measured somewhere in the periphery. So we use some statistical corrections based on the shape of blood pressure waveform and calibrate volume against other reference, or rely on probabilistic relationship between the age and gender, the likely size and pulsatile compliance of the arterial waveform to know the exact cardiac output. And pulse wave analysis algorithm use Windkessel effect or long time interval or multi-beat analysis method or pulse power analysis or pressure recording analytic method. Pulse wave analysis methods are divided into invasive, minimally invasive, or non-invasive method. Invasive methods are externally calibrated, while minimally invasive are internally calibrated or uncalibrated, while all non-invasive monitors are internally calibrated. As the externally calibrated or invasive method or minimally invasive are more accurate, so they can recommended for major surgery like esophagectomy, cardiac surgery, or it can be used in the critically ill patients. While because of the non-invasive methods are less accurate, so low or intermediate, it is recommended for low or intermediate risk surgery. And we are discussing calibrated methods. Flow track and VGL are non-calibrated arterial pulse contour analysis technique. Erlanger and Hooker has the idea that stroke volume can be derived from change in the pulse pressure. So by using this principle, we are using the method to measure the cardiac output. Another thing is, what is the calibration? Calibration is the process of adjusting and validating the accuracy of measurement system by comparing its output to non-standard or reference. This ensures the measurement made by the system are accurate and reliable. Hence, calibrated systems are more reliable for high-risk surgery. When we are studied the calibrated versus uncalibrated arterial pressure waveform analysis, these devices are stable, can be used in well-stable patients, but it cannot be used in high-risk surgery because cardiac output is less dependent on vascular tone, and it has to be calibrated after 8 hours of use, and it cannot be used in patient with severe sepsis or septic shock. Invasive pulse wave analysis method based on they are calibrated against the external reference, CU external reference, by using the transpulmonary thermodilation or lithium dilution method. Among the transpulmonary thermodilation method, Pico monitor and volume view monitor are most commonly used, and it requires central venous catheterization and arterial line, and we inject a small bolus of cold saline via the central vein catheter, and cold saline is mixed with the blood, and there is relative change in temperature which is reflected through the thermistor tip catheter, which is usually placed in the femoral artery or any other great arteries. So Pico system, it is the first system which was approved in 2000 for clinical use, and it uses specific algorithm, that combination of real-time continuous monitoring through pulse contour analysis, and it is calibrated intermittently by transpulmonary thermodilation method, and it analyzes the systolic part of arterial waveform. For this monitor, calibration interval is recommended to be every 8 hours or whenever there is clinically significant change in SVR. This formula is used for the calculation of the cardiac output. In that, systolic portion of a curve is undertaken, and there is the pressure changes over time. PT is the pressure changes over time. SVR is a systemic vascular resistance, and PT is the area under the arterial pressure curve in the systole, and CP is the aortic compliance. DP by DT is the shape of arterial. It can be measured by the shape of arterial waveform. This system has many advantages, like less invasive, useful in pediatric patient because we cannot use Swan gauge in the pediatric patient, independent of ventilatory and respiratory cycle, and measure the global and diastolic volume, intrathoracic blood volume, and cardiac preload. But there are certain contraindications like vascular device insertion when we are using some arterial graft, or there is physiological derangement like aortic wall regurgitation, intracardiac shunt, or we are using extracorporeal circulation. LIDCO is another system which uses two proprietary algorithm and indicator dilution cardiac output monitoring system and continuous arterial waveform analysis pulse cardiac output system. It uses pulse power analysis, and lithium is used as an indicator, and small amount of lithium 0.15 to 0.3 millimole for average adult is injected through the CVC or peripheral IV lines, and lithium concentration time is measured. And stroke volume is calculated from arterial pressure waveform using auto-calibration method. And then nominal stroke volume is measured, which is converted after recalibration to the actual stroke volume. And it works well in patients with peripheral artery disease and less affected by the waveform disturbances. System is less affected by the damping, accuracy compromised under certain circumstances, just like aortic regurgitation, arrhythmia, and severe peripheral vasoconstriction, and patients who are receiving lithium therapy. LITCO Rapid is another system which derives stroke volume from patient arterial waveform using only pulse cardiac output algorithm, and calibration is recommended for every 8 to 24 hours, and it is contraindicated in patients with less than 40 year, patient having first trimester pregnancy, and it is monitor had certain limitations, like it may overestimate cardiac output in patient on lithium therapy or those using muscle relaxant containing quaternary ammonium ions. And it is less reliable in aortic valve replacement, patient on IABP, and patient having poor quality of arterial signal. Volume view is also invented by the Edward Life Sciences, and it introduced in 2010. It uses specific thermistor to tip catheter, volume view catheter in the femoral artery, and it connect to the EV1000 monitoring or hemosphere monitoring. Volume view system determine cardiac output, arterial pressure analysis on femoral artery, and it require external calibration by the transpulmonary thermodilution technique. By this monitor, we can measure the extravascular lung water, pulmonary vascular permeability index, global end-diastolic volume, intrathoracic blood volume, and global ejection fraction. Minimally invasive are further divided into internally calibrated or pulse wave algorithmic analysis system, and there is no external reference. Cardiac output is required for calibration. Only arterial catheter is needing to making them minimally invasive, and estimated cardiac output will calibrate with the algorithm using biometric, demographic, and hemodynamic data along with arterial pressure waveform characteristic. So performance can be affected by the pathological condition, by the liver failure, septic shock, or rapid change in vasomotor tone due to fluid and vasopressor administration. Internally calibrated pulse wave analysis is flow track system. It used arterial pressure based cardiac output algorithm. It analyzes the pressure characteristic and correct the arterial compliance and resistance to estimate the cardiac output. It analyzed at sampling rate of 100 Hertz, and standard deviation of successive pulse pressure is calculated. Vascular tone is calculated based on the mean arterial pressure and arterial pressure waveform characteristics such as skewness and kurtosis, and it also requires factor chi as a time constant for analysis of calibration of the calculation of the cardiac output. Another monitor, ProAct PulseoFlex, is internally calibrated pulse wave analysis. It has proprietary ProAct transducer required, and it has facility of external calibration by echo or by auto calibration with the internal calibration system by age, body weight, height, and gender. It's sampled at frequency of 250 Hertz and estimated cardiac output based on the systolic part of the arterial form. There is cross comparison of cardiac output trending accuracy, LITCO and PICO, flow track, and pulmonary artery catheter. All are having greater value, but utility and validation studies showing only one cardiac output device may potentially not to be extrapolated to equivalency of using another similar device. Argos monitor is by the Ratia Medical USA, and it is based on the multi-beat analysis. Waveform is analyzed over long time interval. It minimizes because it minimizes the disturbance of wave reflection phenomena, and cardiac output estimated on the arterial waveform and biometric data. Non-invasive cannulation of artery and peripheral artery and central vein is not required. We use finger cuff technology or volume clamp method. Non-invasive sensors include finger cuff or sensors are placed on the skin above the radial artery, and sensor measure the blood volume in the finger artery using the infrared photodiode and light detector, and finger cuff inflate to keep blood volume constant in the finger arteries. So change in finger cuff pressure are used to reconstruct the arterial blood pressure waveform, and these are all non-invasive monitor are internally calibrated. This is a clear sight by Edwards Life Sciences. It compensates for hydrostatic arterial blood pressure difference between the finger artery and phlebostatic axis using heart reference system to estimate the brachial artery blood pressure. And algorithm primarily analyze the systolic part of the arterial blood pressure waveform. CNAP system uses continuous non-invasive cardiac output algorithm. It uses intermittent upper arm cuff oscillometry method to scale the finger cuff derived arterial blood pressure waveform to brachial artery blood pressure. It accounting preload, waterload, afterload, contractility, and vascular compliance because it senses whole arterial blood pressure waveform for estimation of the cardiac output, and normogram derived calibration factor based on the biometric data used to obtain the absolute cardiac output. Main limitation of this is impairing finger perfusion, such as disease of vascular disease, circulatory shock, or patient on high dose vasopressor therapy. Radial artery applanation tonometry is mechanical sensor placed on the skin above the radial artery, and these mechanical sensors maintain a transmural pressure of 0 by slightly compressing the radial artery, thereby enable continuous recording the arterial blood pressure waveform. Main limitation is finger movement and impaired arterial blood pressure signal quality. These are DMP life system or T-line system are the radial type of radial artery applanation tonometry. There are certain limitations associated with pulse contour analysis techniques, like dependence of the arterial waveform. It is affected by the arterial artifacts like underdamping, overdamping, or patient is on IABP. It is require manual corrections, and it is also affected by the arterial compliance, just like age or pediatric patient. And it is less reliable in patients who are having rapid hemodynamic changes like septic shock, liver failure, and when there is non-pulsatile flow, it cannot work. So, so it has limitation in patient on ECMO or LVAD. Thank you so much.
Thank you, Dr. Manoj Kamal. It's a pleasure to hear you speak on different methods and the machinery available in today's world for pulse contour analysis, calibrated. And I'm sure there'll be many questions to your talk at the end of this session. Thank you for delivering a good talk. We go over to the next speaker from calibrated pulse contour analysis to uncalibrated pulse contour analysis by none other than Dr. Soumi Das. Dr. Soumi is a well-known cardiac anesthesiologist and a good name in IACTA from West Bengal, with her affiliation to IPJMER and SSKM. She is a person who's always interested in learning more. We recently had her over as a pediatric cardiac anesthetist observer, and she wanted to do so much of pediatric cardiac anesthesia training, even as a professor of her ranking. So when knowledge is scarce and knowledge is an earnest thirst in someone, no one can stop you. So is Soumi Das a good example of the same. So over to her for uncalibrated pulse contour analysis.
Thank you so much, madam. It is such a pleasure, and I'm really humbled by my extensive introduction. Thank you so much, ma'am. So I will move on to my presentation. I hope it's visible. Yes, it should be. So the topic of my today's presentation is pulse contour uncalibrated. And for that, let me just quickly move on to I have no financial or any other disclosures. And this is a brief overview of my entire presentation. I'm going to discuss on what is pulse contour analysis, physiology of arterial blood pressure waveform, pulse wave analysis for blood flow estimation, basic measurement principles, classification of pulse wave analysis monitoring system, calibrated versus uncalibrated, available devices for pulse contour analysis uncalibrated, advantages of uncalibrated pulse contour analysis devices, limitations of uncalibrated pulse contour analysis devices, and the clinical utility.
Dr. Das, can you go for slideshow?
Oh, it's not a slideshow? Right.
Thank you. Thank you.
Yeah. Thank you. So coming to what is pulse contour analysis? It is pulse contour analysis allows estimation of cardiac output based on continuous analysis of arterial blood pressure waveform, a complex interplay between left ventricular stroke volume, systemic vascular resistance, and vascular compliance. So what is the physiology of arterial blood pressure waveform? Essentially, During systole, there is an increase in arterial blood pressure. So the upstroke dilates the arterial, the aorta, and during the diastole, there is decay of aortic arterial pressure. The waveform and amplitude of aortic pressure are related to the stroke volume. However, this relationship is true at the aortic level, but usually we measure the peripheral pressure, which is different from the aortic pressure because of pulse wave amplification phenomenon. It depends on arterial compliance and resistance. Therefore, the arterial pressure measured at the radial and femoral level is different from aortic pressure. So this is how it works. Pulse contour analysis is performed by precise detection of arterial pressure waveform and specially detects the dicrotic notch, performs a geometric analysis of the curve to estimate the stroke volume. For the geometric analysis of arterial pressure waveform to estimate stroke volume, different models use different algorithms like the 2-element Wien-Kessel model, 3-element Wien-Kessel model, model flow and HEMS techniques, long-time interval analysis, pulse per analysis, pressure recording analytical method, etc. So just to give an example, the 3-element Wien-Kessel model, the device estimates pressure at the aortic level and applies a model based on an electrical analogy of the cardiovascular system that takes into account the resistance, compliance, and impedance of the system, and thus estimates the stroke volume and the cardiac output. So what is calibrated versus uncalibrated? So in the previous discussion, we had extensive discussion on calibrated techniques. So now coming to uncalibrated. Pulse contour analysis can be done using invasive technique and monitoring system, minimally invasive or non-invasive. Invasive techniques are externally calibrated, already discussed by Dr. Manoj Kamal. The focus of the topic is uncalibrated, which includes both internally calibrated using demographic data, biometric data, or waveform characteristics, or it can be totally non-calibrated. So unlike the externally calibrated invasive method, which uses the peak at the pulse contour analysis using external calibration using thermodilution techniques, the non-calibrated pulse contour analysis devices either use internal calibration consisting of initial estimation of pulse contour analysis using demographics, biometric data, or waveform characteristics, or incorporating echo-derived stroke volume, followed by continuous estimation of pulse contour analysis and continuous recalibration. So these are the various devices which are available using pulse contour analysis. Flow track, amongst these, the non-calibrated are flow track, Argus, PulseoFlex, Lidco Rapid, minimally invasive internally calibrated. ClearSight, CNAP are non-invasive internally calibrated. Most Care is a minimally invasive and totally non-calibrated device. All are conventionally categorized as non-calibrated devices which do not require any external calibration. So now coming to the individual devices, the flow track. This is, as we all know, it's the commonly used flow track. The hemisphere, using the Acumen IQ technology, can be minimally invasive using invasive arterial waveform or non-invasive when used along with ClearSight technology. Here we have a clinical scenario. As you can see here, the clinical scenario, we can see that the HPI or the hypotension prediction index and the DPDT improves with the use of inotrope. So this is a PulseoFlex, which uses the Pro-AQT technology. This is a Lidco Rapid. This uses a pulse per power analysis technology. The pulse power analysis does not use the morphology of the AP waveform to estimate cardiac output. It translates the original AP signal into a standardized volume waveform based on the assumption that arterial compliance changes as AP changes. The most care system, which is a non-calibrated, it uses the PRAM or the pressure recording analytical method to analyze the AP waveform over the whole cardiac cycle and identify specific parts of the AP waveform that only last for a few milliseconds, called the points of instability. So there are several methods for non-invasive pulse wave analysis. Like, for example, the volume clamp method, the radial artery applanation tonometry. So here we're going to discuss the clear sight system, which uses a volume clamp method. The sensor contains an inflatable finger cuff. Just a minute. As we can see here, and an infrared plethysmograph that measures blood volume in the finger arteries, which is changing during the cardiac cycle as a result of changes in the arterial pressure. An automated feedback system inflates and deflates the finger cuff rapidly in order to keep the volume of the finger arteries constant by applying a contour pressure. From this counter pressure, the AP waveform is reconstructed indirectly and is analyzed by pulse wave analysis to give the cardiac output. So this is a LIDCO CNAP. Now coming to what is the advantage of these devices? Essentially, PCA provides a real-time continuous estimate of cardiac output, and the system is extremely precise. So coming to this article, evaluation, as you can see here, the aim of the study was to evaluate the least significant change of cardiac index, stroke volume index, and stroke volume variation, as well as pulse pressure variation obtained using PCA. They use the PulseoFlex. 50 mechanically ventilated patients undergoing neurosurgery in the OR. Cardiac index, SVI, PPV, and SVV were obtained by PulseoFlex, were recorded every 12 seconds during a 15-minute steady state periods. Least significant changes were calculated every minute. And the result was that the least significant changes statistically differed over time for cardiac index, SVV, PPV, and SVV. Least significant changes range from 1.3 to 0.7% for cardiac index, 1.3 to 0.8% for SVI, 10 to 4.9% for PPV, and 10.8 to 4.3% for SVV, suggesting that PCA is able to detect rapid and small changes in cardiac index and SVI, but the interpretation for rapid and small changes of PPV and SVV must be done with caution. So this is one of the tests which we can use to detect whether the patient has a fluid deficit or not. The end expiratory occlusion test. The relationship between cardiac output and cardiac preload is assessed through the hemodynamic effects of mechanical ventilation. Here we explored the hemodynamic effects of end expiratory occlusion test, which has already been validated in various studies. The test consists of interrupting the ventilator at end expiration for about 15 to 30 seconds and assessing the resulting changes in cardiac output. During PPV, insufflation increases the intrathoracic pressure, which is transmitted to the right atrial pressure, the backward pressure of venous return. The right cardiac preload decreases. As ventilation is stopped in expiration at the level of PEEP, the cyclic impediment in venous return is interrupted and the right cardiac preload reaches its maximum. If end expiratory occlusion is long enough, the increase in right cardiac preload is transmitted to the left side. An increase in stroke volume and cardiac output in response may indicate preload responsiveness in both ventricles, as we can see here. So coming to the limitations of these devices, artifacts like underdamping and overdamping, they affect the pulse contour analysis derived cardiac output. Arterial compliance, aging of the patient, will also affect. Rapid changes in vasomotor tone, septic shock, and liver failure likely leads to faulty cardiac outputs. And non-pulsatile flows like VA, ECMO, and LVAD may also be a hindrance. So coming to the one of these studies, they tested the ability of third-generation FlowTrack Vigilio software to track changes in cardiac index induced by volume expansion and norepinephrine in critically ill patients. They saw that the concordance rates between changes in cardiac index by the pulse contour method and by the thermodilation method induced by volume expansion and norepinephrine was 73% and 60% respectively. The bias between changes significantly correlated with changes in total SVR, concluding that third-generation FlowTrack and Vigilio was moderately reliable for tracking changes in cardiac index induced by volume expansion and poorly reliable for tracking changes in cardiac index induced by norepinephrine. Another study in liver transplant patients, which again proves that FlowTrack may not be very accurate in detecting cardiac output in patients with low SVR, especially. So also the complications may be a hindrance, like even if it's small, there are lots of complications. So after all this discussion, let us come to what is the clinical utility. As we can see, these devices, our non-calibrated devices are less, although less reliable, they are cheaper. Although they provide less information, they are less invasive. So in which scenario would these kind of non-calibrated devices be useful? Especially as we see in OR scenarios where maybe the question which is asked is whether we should be giving fluids or vasopressors, where a simple cardiac index, a stroke volume, SVV and PPV would be good enough. Instead of this intensive care scenario where the patient would require a more invasive thermodilation technique to give more data like the cardiac contractility, the stroke, the lung pump permeability, lung water, etc. Thank you very much.
Thank you, Soumi. That is a very lucid and nice presentation. Very well done. Thank you so much. You have highlighted the use of uncalibrated or internally calibrated pulse counter analysis techniques in clinical scenarios. Thank you so much. And I take pleasure in inviting Dr. Siddharth. He's from Narayana Hospital, Bangalore, Narayana Institute of Cardiac Sciences, Bangalore. He was extensively working in cardiac intensive care unit, and he will be talking to us about mean systemic filling pressure. Thank you so much. Over to you, Dr. Siddharth. Dr. Siddharth, please start.
Thanks, sir, for the introduction. Thanks for the opportunity to giving me an opportunity to speak in such a respectable forum. Myself, I'm Dr. Siddharth. I'm the Associate Consultant, Narayana. I'm going to talk about mean systemic filling pressure. First, let us get the definition right. No disclosures. Definitions, mean systemic filling pressure. First, we need to know about other two terms also. Mean circulatory filling pressure is the pressure that is within that would be measured at all points in the entire circulatory system if the heart were stopped suddenly and the blood were redistributed instantaneously in such a manner that all pressures were equal. Mean systemic filling pressure, MSFP, is the pressure in only the systemic circuit, that is, ignoring the heart and the pulmonary circulation, also in the absence of flow. Whereas mean cardiac filling pressure is the mean pressure in the motionless cardiac chambers and the pulmonary circulation. It is usually 3 mm Hg higher than the other two. This is the normal pressure and in the y-axis, and the x-axis is the various places of the arterial systemic circulation and the venous system, where how the pressure changes happen in the normal circulation. As we see the left side, the maximal pressure is in the arterial side, which depicts the map, the mean pressure. And when this is plotted along the various sides of the vascular system, capillaries, venules, veins, and central veins, this is the curve we get. In the second graph, this one, we can see as the mean arterial pressure drops, the arterial side, we can see this CVP going up, the one in the purple curve. And similarly, but one thing you notice, both meet at a common point of intersection.
This point of intersection is the mean capillary filling pressure or mean systemic filling pressure. This is again both graphs together in normal circulation, which is depicted in red curve, and the purple curve depicting the shock patient. And this is the intersection point which depicts the mean systemic filling pressure. What are the determinants of this mean systemic filling pressure? The tone of the smooth muscle in the systemic circulation determines the pressure within the vascular walls. Here, vascular wall means we mean the venous system, venous side of the systemic circulation, because that is what we are going to focus upon. This tone of the smooth muscle increases the stiffness of the wall or the elastic recoil and affecting the pressure. Next, we come to the volume. This concept of volume is divided into unstressed and stressed volumes. What is this unstressed and stressed volume? The unstressed volume is the volume of fluid in the circulatory system which does not produce any stress on the walls, i.e., measuring the MSF would yield a pressure of 0 mm of HT. So, whereas the stressed blood volume is the amount of blood which exerts pressure on the blood volume beyond this unstressed volume. In this diagram which I have put, you can see, you can consider that when a balloon is filled partially, it is in unstressed phase. When it is full also, it is in unstressed, still the walls are no stress on the walls. Whereas when it is completely filled and you are overfilling it, there is some stress exerted by the wall. This pressure created by within the wall on the venous system depicts the mean systemic filling pressure. Why we are focusing so much is venous return plays a very important role in the cardiac output. So if the venous return is not good, the cardiac output will reduce. That's why it has taken such an importance. At the same time, it is this stressed volume which plays the role in cardiac output more than the unstressed volume. This is again the diagrammatic representation where this is the systemic circulation, and this is the venous side of the circuit, where I already told what is the unstressed volume and the stressed volume. Whereas the mean systemic filling pressure is the difference between the right atrial pressure and the mean systemic filling pressure and the right atrial pressure. Mean systemic pressure is the difference, again, the point of change from unstressed to stressed volume, the pressure exerted on the walls. This again is influenced by the venous resistance on the right side of the heart. If there is any venous resistance, that again affects the right atrial pressure and reducing the gradient between the mean systemic filling pressure and the right atrial pressure. It is this gradient which decides the what amount of blood is going to the right side of the heart, which indirectly affects the cardiac output. If this gradient is less, the cardiac output would be less. Next, we'll come to the venous return. This is again the venous return curve, where the y-axis shows the cardiac output or the venous return, and the x-axis shows the pressure. Where you can see the blue line is the venous return curve, the red line is the cardiac output curve. Both intersect at a common equilibrium point. It is at this equilibrium point most of the cardiac output and the flows take place for the body. So this is the very important pivotal point. When this equilibrium point is traced towards the x-axis, that is the point of right atrial pressure. When this venous return curve is intercepted at the x-axis, that gives the mean systemic filling pressure. The difference between the mean systemic filling pressure and the right atrial pressure gradient, this pressure gradient draws the venous return into the right side of the heart. And also at when the right atrial pressure falls beyond a critical point of right atrial pressure, how much ever the right atrial pressure falls, there won't be increase in the venous return. This is called as a point of vascular waterfall. And usually in normal conditions, the mean systemic filling pressure is around 2 to 10 millimeters of mercury. But in cardiac surgery and septic shock patients, it can go up to 15 to 33 mm of Hg. Next, we come to the venous return curve. What is this venous return curve formula? This venous return curve formula basically means the difference between the mean systemic filling pressure and the right atrial pressure divided by the venous resistance. Basically, this difference in pressure is directly proportional to the venous return. At the same time, the venous resistance is inversely proportional to the venous return. If the venous resistance is high, the venous return is less. If the venous resistance is low, then the venous return is high. What is the role of mean systemic filling pressure in common clinical situations? First is the commonest one is hypovolemic shock. What happens here? In hypovolemic shock, overall the blood volume is reduced. So what happens when you follow this cardiac output curve, where the y-axis is the cardiac output and the x-axis is the pressure, you can see that there is reduction in both the mean systemic filling pressure and the right atrial pressure in a proportionate manner whenever there is hypovolemia, hence leading to shift of this equilibrium point downwards in the cardiac output curve, indirectly telling that the cardiac output is reduced. Always this, though the volume is the decrease in cardiac output is due to reduced blood volume. This volume, the gradient between mean systemic filling pressure and the right atrial pressure is maintained here. It is only the volume difference. So these patients respond to volume. Next, we come to cardiogenic shock. In cardiogenic shock, what happens? The cardiac output curve becomes more flat and the slope of the cardiac curve becomes more flat compared to the normal curve where the slope is high. Here, what happens? The mean systemic filling pressure doesn't change. Due to the reduction in the cardiac function, the equilibrium point is shifted towards the right. Hence, the equilibrium point is down, and this leads to the rise in the right atrial pressure. This right atrial pressure leads to decrease in the gradient between the systemic filling pressure and the right atrial pressure, leading to decreased venous return and cardiac output. Next, we come to septic shock. What happens in septic shock? In septic shock is a very tricky situation. Here, we can see that the red dotted line in the center is the normal cardiac output curve. In septic shock, what happens? There is vasodilatation, both systemic and venous. So what happens when there is venous vasodilatation? There will be drop in the overall mean systemic filling pressure. At the same time, there will be the gradient between the mean systemic filling pressure and the right atrial pressure will be more. But what happens when in the arterial side of the circuit, since there is systemic vascular in the arterial side of the circuit, the systemic vascular resistance is less. So the cardiac output is better. So the resistance is less, SVR. So that leads to a hyperdynamic state. Whereas when this sepsis causes cardiac dysfunction, then this cardiac output curve becomes more flat and behaves like a cardiogenic shock curve, where the equilibrium point is shifted downwards and outwards and leads to the increase in the right atrial pressure and cause decreased cardiac output. What is the effects of volume? Always all of us are worried when the patient is fluid responsive, when the patient is not fluid responsive. So first we have to know there will be some set of patients who will be fluid responsive, some patients will be non-fluid responsive. Patients who are fluid responsive will be in the steep side of the cardiac function, cardiac output curve. So here what happens, whenever the difference between the mean systemic filling pressure and this thing gradient is maintained very well. So in these patients, they respond to volume and there is increase in the cardiac output. Whereas when in the steep side of the curve, when the already the chambers are very well dilated and the cardiac output is at its maximal, the slope is less. So whatever volume you give, it doesn't bring about major difference in the cardiac output, because as depicted here, because there is no major difference in the systemic filling pressure and the gradient. These will be non-fluid, non-responsive. What is the role of norepinephrine? Norepinephrine is a vasopressor which causes vasoconstriction of the splanchnic bed and shifts the unstressed volume of blood which is in the venous system into the stressed compartment, hence contributing to the cardiac output. This is how norepinephrine helps in improving the cardiac output. Then what is the role of passive leg raising? Again, it is a pseudo fluid challenge situation where we passively leg raise. It increases the venous return and increases the mean systemic filling pressure, shifts the blood volume from unstressed compartment to the stressed compartment and increases the venous return. What happens in prone position? It is quite tricky here. In prone positioning, especially when we give in ARDS, what happens? Already the pulmonary vascular resistance is high due to hypoxia and hypercarbia. So whenever you prone, when hypoxia and hypercarbia is corrected, the pulmonary vascular resistance goes down, improving the right ventricular contractility, reducing the right atrial pressure, and hence increasing the venous return and improving the cardiac output. But the one thing we have to always keep in mind that whenever there is raised intra-abdominal pressure, both passive leg raising and prone positioning will be more detrimental. Lastly, measurement of mean systemic filling pressure. There are three ways to measure mean systemic filling pressure. First is the mechanical heart-lung interaction. The second method is by using the isolated arm technique, where the one arm is used as a surrogate for the whole circulation. Lastly, as a mathematical approximation of mean systemic filling pressure using Parkin and Leaning method. This is still in the research phase. Still, there is no definitive conclusion on the formula. Whereas one of the drawback of the second method, that is isolated arm technique, is the muscle tone of the arm also plays a role in venous tone. So it will be detect higher mean systemic filling pressure. Interestingly, all methods yield unexpectedly high values closer to 20 when the actual is around 10 is the mean systemic filling pressure. Lastly, I would like to tell how the mechanical ventilation method helps. Here, the cardiac output and the CP or RA pressure is plotted in a serial inspiratory hold of peak inspiratory pressure. They are 5, 15, 20, and 25, and they are plotted along the graph, and the x-intercept is the mean systemic filling pressure. Usually, this is very risky in ARDS patients because it will cause hemodynamic instability. This method can't be used even in hemodynamically unstable patients. Still, we have to do a lot of research into how to detect mean systemic filling pressure. A lot of research needs to be done. Thank you.
Thank you, Siddharth, for that lucid explanation of the mean systemic filling pressure. Thank you very much, and also describe the various techniques to estimate the mean systemic filling pressure. Thank you so much. Please stay back
Thank
till
you.
the end of the session.
Thank you, sir.
And please unshare your screen. The last talk is about invasive cardiac output monitoring that I'll be doing in a very quick manner because we already reached the time limit. So I will do it as soon as I can. In the next 10 to 12 minutes, I would like to deal with the subject of invasive cardiac output monitoring, which is essential in patients who are critically ill and patients who are undergoing high-risk surgery. These minimally invasive, semi-invasive, non-invasive techniques are good when the patients are reasonably having a good cardiovascular status, but in patients who are unstable and who are undergoing high-risk procedures, we need to have a more realistic uh, um, measurement of these parameters, especially the cardiac output, to be able to manage the macro circulation in a very good manner. So here comes the role of the invasive techniques. The ideal features are mentioned here. It should be nurse driven and it should be accurate, and it can be continuous or intermittent, and these monitors can be or variously divided into minimally invasive, non-invasive, less invasive, and invasive. And please note that sometimes these words like less invasive and minimally invasive or semi-invasive are used by the trade to make it more attractive. And we should always know what is happening behind the scene when we are about to know more about these products and mentioning to use them in clinical situations. Coming to the invasive cardiac output, the thermodilution technique has become the more clinical standard, most commonly used for measuring the cardiac output. It is validated and it is the gold standard method for measurement of cardiac output. In fact, all the techniques which have been described so far use pulmonary artery-derived cardiac output as the standard for comparison. And hence, the pulmonary artery catheter-derived cardiac output measurements are the gold standard for the monitoring cardiac output in most situations. You know that the pulmonary artery catheter itself is 110 centimeters long, made of polyvinyl chloride, and it is radio opaque, and you have 10 centimeters marked on the external surface, and it is heparin coated so that it can stay in the circulation from thrombogenesis. And we are all aware how it passes into the right atrium, right ventricle through the pulmonary valve into the pulmonary artery and gets wedged into one of the branch pulmonary arteries. This is the intermittent technique of measuring cardiac output. To inject cold saline, a known amount is injected in the right atrium, and it passes through the circulatory system on the right side across the tricuspid valve into the right ventricle pulmonary artery, and the temperature change is sensed at the thermistor, which is located at the tip of the catheter, and then you get a cooling curve based on which you can determine cardiac output. Similarly, in the continuous cardiac output, there is a thermal filament which is incorporated in the structure of the catheter itself, which is a pseudo-random fashion, in a pseudo-random fashion, heated to about 40 degrees centigrade, and the resulting increase in the temperature is sensed at the tip of the catheter. And here you get the heating curve rather than cooling curve. Intermittent technique where you use cold saline, we get the cooling curve, whereas here it will be heating curve, and we determine various parameters, the cardiac output, stroke volume, systemic vascular resistance, pulmonary vascular resistance, and also we can derive a parameter like arterial oxygen content, mixed venous oxygen content, and the saturation, and we get the arterial venous oxygen content difference as well as the saturation and also the oxygen consumption, which is usually about 250 ml per minute per meter square per minute in a 70 kg individual. And these are some of the parameters which are derived to the pulmonary artery. We are all familiar with it. And the how you get the derived parameters are described here, various formulae, and same thing here. And the pulmonary artery catheters are also extremely useful in terms of that is the only way to get the mixed venous oxygen saturation, and also to determine the pulmonary vascular resistance and systemic vascular resistance in a readily available fashion. And the possible clinical indications of pulmonary artery catheter monitoring, catheter-based monitoring is indicated. on the right side of the slide. According to our experience, we use it in patients who have poor LV function, right ventricular failure, pulmonary arterial hypertension, especially those who undergo the pulmonary endarterectomy, patients who undergo left ventricular assist device and heart transplantation, and in patients who have severe diastolic dysfunction. There are no absolute contraindications. Please note this point. This is from the recent textbook. It says clearly that there's no absolute contraindication. All the contraindications are relative. Patients have tricuspid pulmonary stenosis, and I really find it sometimes difficult to place a pulmonary artery catheter who has undergone tricuspid valve repair. So if you want to use a pulmonary artery catheter, in such patients, maybe you should use it before the repair is done. And patients have right atrial or ventricular masses, of course, so you would like to use it or use it with caution, or just keep it in SVC and float it at the end of surgery when the atrial mass is removed. Severe arrhythmias, left bundle branch block, newly inserted pacemaker wires, all these are related to. I would like to again stress the point that this in the recent textbook of Miller, they have written that there's no absolute contraindication. If the patient needs it, just do it. When you're doing the cardiac output measurement, the underestimation of the true cardiac output is seen if the injected volume is greater than the programmed volume. Large amounts of fluid are being administered simultaneously or concurrently as you're measuring the cardiac output. Injected colder than the measured temperature, and overestimation of true cardiac output occurs when the injected volume is less than the programmed volume, and injected is warmer than the measured temperature injected. Other considerations are surgical manipulation. Of course, you get a wrong reading, especially when the heart is lifted in off of the ABG. You do not expect to get the correct information when the actually thermistor filament or the thermal filament in a continuous cardiac output PA catheter may be touching the RV wall when the heart is lifted, and hence I would not depend upon what is shown on the monitor when the heart is positioned, verticalized, or displaced during the distal grafting during off-pump CABG. To this list, I would also add that patients who have intracardiac shunts and patients who have severe tricuspid regurgitation, the values derived using the pulmonary artery catheter derived cardiac output will be are likely to be likely to be erroneous. This publication clearly shows that the hospital mortality is decreased when invasive hemodynamic monitoring is used in cardiogenic shock. And there are several publications which have highlighted that pulmonary artery catheter is a critically important component of monitoring in the cardiovascular critical care. The pulmonary artery catheter is often copied but cannot be equaled. You have so many um, methods which have been already described today. So for example, you can see that if you use the esophageal Doppler, the percentage of error is 40%. Can you believe that? And when using the partial carbon dioxide deep breathing technique, the percentage is 44%. Bioimpedance technique, it's 40%. So unquestionably, PSA, I do not think that we should use it routinely, but when the patient is actually not well, when the cardiac index less than 2.2 liters per minute and the right atrial pressure and left atrial pressure greater than 18 millimeters, and patient is in septic shock condition, there's nothing better than pulmonary artery catheter to tell us what is actually happening and what are the how to treat that. What is the pulmonary artery, pulmonary vascular resistance, systemic vascular resistance, and then based on these values, you can always titrate the vasoactive agents to be able to provide the optimal care. In the last 2 decades, especially from 1990 to 2010, there have been several publications which have questioned the use of pulmonary artery catheters, but we feel that there's a definite in place for the use of pulmonary artery catheters in critical patients and cardiac surgery patients. These studies, which were published between 1990 to 2010 or even later than that, all of them had problems in their study design, and most of the patients, the randomization, patient sampling method, and crossover were not optimal, and there were some crossovers. And some of these studies did this procedure when the patient was actually collapsing and intensive care units as a last resort. And hence, I don't expect that pulmonary artery catheter is going to save this patient when you are using it as a last at the fag end of the patient's life. So there were several problems in the study design, etc., which are highlighted in this slide. And we also have analyzed the use of pulmonary artery catheters, and we feel that um, it has a it has its own place, and it should not be thrown out of the window as it something else better than pulmonary artery catheters existed. With that, I would like to conclude my talk because we are already close to 9 o'clock. I would like to have some amount of discussion before I hand over the session to the panelists. I would like to announce that we will be having critical care echocardiography fellowship examination in December, and also the workshop. Come see me in December. Please join us. And with that, I request all the panelists, Dr. Ratan Gupta, Poonam, Malhotra, Jigisha, and the speakers, Satyajit, Vinod, Manoj, Soumi, Siddharth, to unmute their mics and switch on their videos and look into the chat box and address the question. Thank you so much.
Dr.
Yes.
Muralidhar, thank you.
Yes,
that
yes.
was an excellent summary of
Thank you.
invasive and non-invasive cardiac output monitoring through the last 40 decades. I just want to highlight one thing. The use of Manoj and Soumi did it very beautifully. The use of pulsatile contour analysis, calibrated and uncalibrated in abdominal surgery has come up in a big way in a Pegasus trial. And they have overlooked quite a few problems by saying that we need algorithms and protocols in place. And these algorithms and protocols, if well interpreted and well adhered to by the whole team, and you see the trending, then the outcomes of the patients as to when to give fluids, when to give inotropes, and what to see and have target values of cardiac output. Like if I say in one of the examples that they quoted is that if you have a target output of cardiac index and you are using with that approach of full cardiac preload reserve in the goal directed cardiac therapy algorithm, then when you are targeting either the cardiac output or the stroke volume maintenance, you should have your cutoffs. So your cutoff could be PPV of 12% according to the Pegasus. It could be an SVV of not 10% but 5% or less than 5%. So whatever is your protocol for that patient population, which is more than 18 kg in weight, have the trending and see the trending and optimize the use of perioperative goal-directed therapy with these, particularly the uncalibrated pulse contour analysis. It's a very beautiful study. I would urge everyone to go through the Optimize 1 and Optimize 2, as well as the Pegasus trial, which is not for the cardiac surgical patient, but for an abdominal surgery patient. And to conclude, that perioperative goal-directed therapy, in which we have also researched through different PA catheters with their pluses and minuses, through different pulse contour analysis machines, and also with the Starling and the bioreactance and the bioimpedance machines. These protocols help us in titrating the fluids, help us in titrating the inotropes and vasopressors. And if you have predefined target values in your protocol, you score high. I just want to emphasize that point. Your patient's trending is good. Thank you so much for this opportunity, and good luck to everyone. Thank you.
Thank you for your input, and be available, because if some difficult question is there, you can address that.
I will.
There's one question I think Vinod has already put it in chat box, but it will not reach the audience because the audience is having a different link. So the question is bioreactants with IABP.
Yes, sir. Bioreactants is considered to be useful even in patients with IABP, but unfortunately, there are not many studies which have proven its accuracy. But from this one side, they say it's quite useful even in patients who are on
Right.
IABP.
Right. I would like to ask Dr. Satyajit about the hypotension prediction. And so my basic problem is I want to know if I give propofol, if the blood pressure will fall or not in a particular patient. So do you have any mechanism? I'm asking a funny question, but I want to know because this is a crucial thing for anesthesiology. I want to know if the patient is going to become hypotensive if I give a standard dose of propofol. So is there any insight into this?
So, sir, when I had broadcasted the pitfall slide, that's exactly the point which I had made, is that when the index event is sudden, the HPI is not going to be able to work because it needs to understand how the waveforms decay over a period of time for us to have that predictive capabilities.
Yeah. No. My question is, not all patients fall their pressure. So is it possible to say that if I give X amount of propofol to a patient, this patient will not have a decrease in the blood pressure, or this patient is going to have a decrease in the blood pressure?
So, see, the problem with propofol is the patients who will have a hypotensive event will have it in less than a minute. Once we start the drug, the time to the event is going to be less than a minute. And we know that the best predictive capability of these HPI monitors are all more than a minute. It's not less than a minute. So for very acute changes in the blood pressure, it is not going to be able to work.
Maybe the HP is more than 70 or 80, you should not use propofol. Can I say that?
Again, it will not, because the event is so acute, it will not be able to tell us whether the patient is going to have a fall in the blood pressure because of propofol, or the fall is going to be because of something else. So that's the problem with it.
Thank you for your response. And there is one question on can PICO be used in PR patients with tricuspid regurgitation? PICO is a calibrated system, so Manoj has to answer this.
Yes, sir. Pico can be used, but accuracy is very less because any shunt is there or any anatomical or physiological alteration in the blood flow in the heart, then the readings is not very accurate. So it is not reliable method to use in patient with TR patients.
I agree with you. Any other opinion on this? I agree with Manoj, but if somebody wants to say something, please feel free. The other question is, yes. Somebody wants to say something. Dr. Vinod, I just wanted to know, in your first patient,
Yes,
the
sir.
LVEF was 50% and all, but why the lung water was increased?
The patient was a known case of ischemic heart disease, sir, and his ejection fraction also was quite low. I mean, it was 51%. So maybe he was in a mild failure or something like that.
That's interesting.
Actually, in all cases of heart failure, especially of chronic standing, the extravascular lung water, which is a good preload marker as well, could be high or low. So one has to take that value with other values into account. So let's say I have a patient who has a distributive or an anaphylactic shock. Now, this kind of a distributive shock, which may impendingly lead to sepsis and then to acute heart failure, the SVRI as well as the extravascular lung water could be high, very high, in a 60 kg, in a 60 years old male and above. It could be more than 4,000, the SVRI. And also your extravascular lung water would be above 20. But when the moment you have a long standing, this becomes from acute to a chronic, and the sepsis becomes very imminent with no relief of sepsis, then there will be a lowering of this SVRI as well as of the extravascular lung water. So something that was high becomes suddenly low because of onset of sepsis and in heart failure has to be looked into with 3 parameters in mind. The cardiac index, sepsis is one condition where you have the, especially the anaphylactic sepsis, where you have the cardiac output on the cardiac index very high and the SVRI very low. And heart failure may have initially very high SVRI and a low cardiac output, and then chronically, as the patient becomes like a distributive anaphylactic shock, the SVRI comes down and so does the cardiac index. So one has to see the trending over a period of time. One has to correlate 3 parameters, cardiac index with SVRI and with extravascular lung water. Wet lungs and extravascular lung water go hand in hand.
Yeah, I agree with you, but only I asked because the LV function was reasonably good. 50% EF is a preserved ejection fraction patient. So I would think that this patient might have had diastolic dysfunction with preserved
Yes, you're
ejection
right.
fraction. That's why he was having probably, I do not know the diastolic in that patient. So that's what I
No,
thought.
you're right. You're right.
It could be happening.
Yeah,
Yes.
you're right. Diastolic dysfunction, especially grade 2 and above, also causes extravascular lung water to be low.
I have a question for Dr. Vinod.
Yes, sir. Yes.
Vinod, what about patients with chest open thing? Can you use a bioreactance or bioimpedance?
Yes, sir. Yes, sir. That has been validated, and they have said that you can use bioreactance even in chest is open.
How would the numbers compare with the PA catheters, and will it be same or will it be different?
There are at least 4 or 5 studies which have said that it's almost acceptable range with the pulmonary arterial catheter. It's almost on the same range. There are a good number of studies which have said that they are comparable. And the fact that in open lung also you can stick the electrodes on the sensors on the back of the patient, and definitely they have been measured the cardiac output even in open lung, open chest. Yes.
Dr. Vinod, sir,
Yes.
it was a nice talk, and I have a question about what is the role of this electrical bioimpedance in pediatric and neonate. Recently, one company from Osipka, Icon electrical bioimpedance machine is available, and they are claiming they are using in a pediatric and neonate as well as adult. So, any idea about pediatric neonate?
Yes. Jigisha, I can give you this answer. We've been using the bioreactance 1 as well as bioreactance 2 by Ospica for the last more than 10 years now. It's a wonderful machine. It's something that gives you, on the basis of a mixture of bioimpedance and bioreactance, a very good, when in pediatric children, you don't have a PAC, you don't have, most of the machines are above 18 to 20 kg weight for non-invasive cardiac output monitoring. Except for echo, you have no continuous trending monitor available. Reactance and bioimpedance by Ospica fills in that gap. It's a wonderful machine. Like you have any bioimpedance machine, you put your ECG stickers, they come with the company logo, and you have a small pocket size like a pacemaker machine, which can also, in the new bioreactance 2, you have it mounted on a stand, and you put it with a computerized visual monitor, and you have such good values of all your functions, your total fluid content, your cardiac index, all your preload and afterload markers. Everything is so good. If you just punch AIMS and bioimpedance, you'll have at least 10 to 12 very good papers and publications on this in pediatric patients. It is, if anyone wants to invest, the bioreactance 2 is the machine to invest in for pediatric cardiac output monitoring. It's got a 78 to 80% efficacy, and the sensitivity is to the tune of 85% and above. The specificity is even higher, about 92%. We've compared it with transesophageal cardiac output monitoring, which for cardiac index, which gives you no trending. This monitor does. And especially for wet lungs, for total fluid content, it gives you a very good value of your thoracic volume of water as well as your fluid in pleural effusions and pericardial infusion patients of heart failure in children. It's an excellent machine.
They had given demo and I had used in pediatric neonate case, but SVR and SVRI were very high in like 25,000, 23,000 values. So
these patients are in failure. They approximate, as I said, the efficacy is not 100%. It's about 90-95%. Again, based on bioimpedance. It is of no value once the chest is open, but it's a good baseline monitor to have and compare with echocardiography.
Yes, ma'am. Thank you, ma'am.
We use this bioimpedance method. And when the chest was open, we got all erroneous readings. Dr. Ratan will remember.
Yeah. I remember it. The numbers are not correlating at all.
Yeah, when the chest is open,
but nothing.
Vinod has said that in reflectance.
Bioreactance can be used, sir.
Yeah. That's what you said. But when you use the bioimpedance, we did not get. We all got all haphazard values, which had no correlation with the patient's condition.
So the new bioreactance biospica is less of bioimpedance and more of bioreactance. Makes up for the values.
That's right. There's one question on what inference do we get from SVRI? SVRI, Systemic Vascular Resistance Index. It should not be mistaken for stroke volume index. The two parameters are entirely different. Stroke volume index is the stroke volume index to body surface area. The normal values are 35 to 60 ml per beat per square meter body surface area. Whereas systemic vascular resistance index is a calculation of the systemic vascular resistance divided by the body surface area. Normal systemic vascular resistance is 800 to 1600 dynes per second, dyne second per centimeter raised to the power of -5. So the systemic vascular resistance is important. Index is also important when you're treating patients who have hypotension, whether the systemic vascular resistance is high or low. Depending on that, you can choose your vasoconstrictor or vasodilator as per the resistance value. That's a useful parameter in clinically ill patients. Anybody would like to add anything to that? Jigisha, Satyajit, what is the value of SVRI is the question.
I would just like to add it's a very good monitor for sepsis and for high cardiac output failure. When you have sepsis and your SVRI is high and your cardiac index is high and your SVRI is low, then you can delineate the type of sepsis. In an anaphylactic distributive sepsis, SVRI would be very, very low. Whereas in a sepsis, which is due to hypovolemia or due to septicemia itself, a septicemic shock patient, the SVRI would be very, very low, high. So you can delineate the type of sepsis and also the kind of heart failure, which I had spoken of earlier, that in a patient of chronic heart failure, the SVRI may remain very high. In adult patients may go up to 4,000. So it should not be alarming in those patients. That's what the importance of SVRI over and above SVR is for afterload in heart failure patients due to diastolic dysfunction again.
I have a question for Dr. Murali.
Yes, sir. Yes, sir.
Sir, what would there be a role for PA catheter in a patient with central VA ECMO when you're trying to wean the patient from ECMO?
Central VA ECMO. See, my understanding is that sometimes there is a tendency for removing the PA catheter in patients once the patient goes on VA ECMO, but I would like to retain it not only to just to see that there's no cardiac distension, LV distension occurs very easily in these patients, especially if there's no LV vent. So if there's no LV event, I would like to keep it and see what is happening with the LV, whether it's getting distended or not, so that before the pulmonary edema sets in, I can do something about it. And if you are coming off the VA ECMO, certainly I would like to use it. Absolutely no doubt about it. And of course, it should be supplemented with echocardiographic parameters, especially the LV and RV ejection fraction and the LVOT BTI. I would like to measure, and also to measure the tissue Doppler of the lateral mitral annulus. I would like to measure. These are some of the parameters which I like to have handy when you are weaning the VA.
So how do you use
I
the,
think you will agree with me.
yes, sir. How would you use the cardiac output, cardiac index? Will that number mean anything on VA ECMO, or it will be skewed up? That's what I feel.
Absolutely, it will indicate what is the amount of blood flow through the pulmonary circulation going through, but it will not tell us what is the cardiac output in terms of ECMO flow plus the native cardiac output. So what is the native cardiac output? It may tell you, but the total flow, which includes the ECMO flow, systemic flow, it will not tell us.
Thank you, sir.
Also, Dr. Ratan, on VA ECMO, right heart pressures with a PA catheter that we get are very important to tell us about an impending RV dysfunction on VA ECMO. So when you have RV dysfunction happening, sudden rise in right heart pressures, in which CVP alone is not sufficient, the pulmonary artery pressures will tell you a lot about. So something like this, you can't even measure on an echo. So even when you're doing echo and ECMO, you need numbers, and you may not get numbers. You may just be able to visualize RV distension or maybe a TAPSE. But at the same time, a PA catheter, PA pressure suddenly going high is also a good monitor with the PA catheter on RV function. But it doesn't tell you much about the cardiac output. The PA pressure and the wedge pressures are important for RV dysfunction happening on VA.
Thank you, ma'am.
Thank you, Dr. Poonam, for that input.
I just wanted to ask, madam.
Yes.
Patient is on VA ECMO. We are giving a full circulatory as well as a pulmonary support. So what exactly would be the causes for RV dysfunction or RV dilatation?
RV function happens, dysfunction on VA ECMO happens because of LV dysfunction. There is heart failure. That's why you put in an ECMO. When you're on a central or a percutaneous peripheral ECMO, then LV dysfunction is there, but RV dysfunction is generally overlooked, except for doing an echo to see. The reason for RV dysfunction is ventricular interdependence. You already have a big heart which is in failure, and you put in an ECMO, you decompress the heart. ECMO is providing the partial cardiopulmonary support. But when you are weaning off, or there are times when you have some kind of a clot or a thrombosis happening on VA ECMO, or you have a period in which there is sepsis setting in, there is patients having fever, and hemodynamic deranges are happening, and you are not able to decipher the cause of this hemodynamic derange. It could be sepsis leading to heart failure. All these causes of sepsis, intracranial bleeding, any kind of bleeding or thrombosis, and an obstruction to the flow through the cannulas, or a shunt through the cannulas. Sometimes we've seen that the cannulas migrate from the RA into the RV through the interatrial septum. And this causes a sudden increase in the LV dysfunction. The LV distends, the aortic valve back pressure changes, closes, and then suddenly RV dysfunction also happens. So this sudden increase in PA pressures in such a scenario where you need an LV venting on VA ECMO and you're not aware of it, the PA pressure tells a lot. And RV dysfunction due to LV dysfunction and LV distension and aortic valve closing on ECMO is a disaster. It makes the ECMO absolutely a big failure. So it's good to have a trending with the PA catheter, and it's good to monitor on an echo as well. Or any four of the complications on ECMO may happen, causing RV dysfunction: sepsis, intracranial hemorrhage, catheter migration, catheter complications, and sudden decrease in the ECMO flows. And this could be due to a clot or a thrombus anywhere in the circuit. Maybe an oxygenator failure, maybe a hypoxia. Any of them complications will lead to RV dysfunction, with sepsis, of course.
Thank you so much. We are just crossed the time limit of 9 o'clock. So the dinner is getting cold. Before we close it,
Thank you.
I would like to ask each one of you who want to say quick question or comment. After
Thank
which
you, Dr. Muralidhar. You keep us on your toes by keep visiting and learning from the juniors and trying to read ourselves. I have to thank you. Thanks a lot.
Thank you for saying that I am turning like I am learning from juniors. That's correct statement. Thank you. Anybody wants to say anything else?
Thank you, sir. I would like to thank you once again for giving me this opportunity. It was a wonderful platform, my first one for the ICA, and I surely enjoyed.
Thank you so much for joining. Thank you so much.
Thank you very much, sir. It was a great
Thank you, sir.
meeting.
Thank you so much.
Thank you.
And
sir.
I take pleasure in thanking all of you for joining this webinar. On behalf of ICA, I would like to thank Dr. Ratan Gupta, Dr. Poonam Malhotra, Dr. Jigisha, Dr. Satyajit, Dr. Vinod, Dr. Manoj Kamal, Dr. Soumi and Dr. Siddharth for being with us, and all the others who have participated. And we look forward to having you again. Thank you so much.
Thank you, sir.
Thank you. Thank you, everyone.
Thank you very
Thank you
much.
so much, sir. And thank you so much to all of you for giving us this opportunity to host this session. And good night to all of you. Thank you.
Bye-bye.
Good night, everyone.